hold a very, very important role in front of us to be able to help us to tell about the story of diagnosis for the patients. Okay, so to tell you, chest x-ray, yes, indeed sounds very simple and very nice, but when we are going to look into detail into that, it's a very interesting thing, not just for the radiologists, but also for the cardiologists as well. So let's try to have a little bit of brief outlook. So what happens is, this is how is the radiographic density. If you'll go from the air to the metal, so metal is the one which is going to be the most transparent one. However, A is the one which is going to be the least opaque one. And this is how, if you will be looking at the upper chest, in fact, so looking at the bone, looking at the soft tissues, at the ear as well, so it definitely looks slightly different, right? So if we have are able to look into this, so there are some technical aspects of that. So what I call it as P verb. P verb means P stands for the patient details. So then comes the V for the view. So is it AP or PA or lateral view? Then comes the exposure. Is it adequately exposed or underexposed? Then comes the rotation, R for rotation. And finally comes the breathe. So which is inspiration film or an expiration film. So about the views, as I already said it, uh, there are various views for that, and one of the most common one is the PA view, postero-antero view. So in fact, this is the standard view which is taken for routine chest X-rays and taken in full inspiration. And coming to the AP view, what happens is a lot of times those patients are a little sick as well. They are not able to stand or non-cooperative. So what mm, is done is the heart is actually as a greater distance from the film and appears, that's why it appears a little enlarged. So don't try to be in a hurry to make a diagnosis of cardiomegaly, especially in this view, okay? So then comes is the PA or the AP view. So what is the difference basically about that? So basic difference is by looking at the clavicle itself, you will be able to see. So if it is above or over the lung field, this is the PA, okay? Otherwise, if it, and otherwise if it is just at the lung apex itself, so it is AP. Similarly, if you'll try to look for the scapulae, so how do you see? So the scapulae, if it is going to be away, so this is where you see those scapulae. If it is going to be away from the lung fields, so this is PA view, okay? And similarly, you should try to also visualize for the posterior ribs. Are they, visible or not? If you are able to see, yes, this is the normal PA view, in fact. So one of the common things which I try to remember, especially in my early days, is PP. In the PA view, you see the posterior ribs as well. Okay, the over the clavicle is also O over the lung fields, in fact, and yes, heart is normal. So that is one of the reasons as well. You try to mostly ask for is PA view. So now, what about the other views like the lateral view? So lateral view, L is for lateral view. So if you're trying to look for the lung lobes, mediastinum, or even the bony thoracic cavity as well, you can see much better in this view, in fact. Okay, and as I said, L is the thing you should try to stress upon. So, for example, if you're trying to look for fluid in the lungs, or even basal consolidation, or even in the lungs as well. Otherwise, even for pacemakers as well. So yes, AP views or PA views people may ask, but even lateral views are considerably important for this. So something is called as lateral decubitus. Decubitus is what happens is whenever you're trying to see further, there's a very small pleural effusion, or if there's a pneumothorax as well, so you will be able to distinguish upon it. So for example, if you look carefully, I'm going to show you some more examples as well for this. Then one of the things which I had said it about is the exposure. So for example, when do you call adequate exposure? Intervertebral spaces, if they are barely visible through the heart shadow, that is the one which is called as adequate exposure. However, overexposed film is the one in which the intervertebral discs are, or the spaces are clearly visible through the heart shadow. For example, as you may notice, the first one. However, the underexposed is the one, it's opposite, of course. Yeah. So, what about the rotation? So, rotation is what happens is uh, the film is centered when there is equal distance between the medial end of clavicle and the midline. So, this is the imaginary figure. You have to put it in between. Okay. However, so if you look carefully in this, the second figure, so there is slight rotation, right? So about the good inspiration, if you are able to see 6 anterior ribs and 10 posterior ribs, so this is a good inspiration film. Otherwise, if it is going to be an expiration film, so what happens is, yeah, you will be able to get some false impressions about the congestion, or diaphragm may be slightly more higher as well. So a lot of times, especially whenever we are trying to do the cryoballoon ablation patients as well, so it can give a false picture. So one of the important things which we all should know is, how does normal chest X-ray look like? So this is how is the normal ideal chest X-ray, if you will be able to look. So initially, as I already had said it, so the technical aspects you have to see in terms of P verb, patient's details, view, exposure, rotation, and the breath, which is inspiration or expiration one. So after you have commented, so now let's try to go deeper into the interpretation of the chest X-rays. So again, my mnemonic for you guys is going to be A, B, C, D, E, F, G, H. Okay, everyone knows those alphabets. So A for airway, B for bones, C for cardiac shadow, D for diaphragm, E for effusion, then F for the lung fields, G for the gastric bubble, and H for the HeLa and mediastinum. So let's try to have a look. What do we see over here? So, so now in the airway. So in the airway, there are a lot of airways and the other structures as well, which you can see over here. For example, so most of these structures are already named over here, which are the cardiac shadows, the different areas which you can notice over here. Hmm? Right from the aortic arch as well, pulmonary trunk, the left main bronchus, the left atria is over here, in fact, the left ventricle, the oblique fissure as well. You will be able to comment. Then comes the diaphragm, costophrenic angle, the gastric bubble as well, you can see. Then the diaphragm, IVC, oblique fissure, right atrium, horizontal fissure, right main bronchus, the superior vena cava, and also the manubrium, in fact. So, as I was telling you about the counting of the ribs, so counting of the ribs is important for what parameter? If you all can remember, why the counting of ribs is important? As I had said it, if it is a good inspiration film or not. Good inspiration film, I had said 6 anterior ribs are going to be visible and 10 posterior ribs. 6 is to 10 ratio, okay, is going to be visible. So that is why you should be able to count those ribs as well. One, two, three, four, five, six. Hmm? Like this. It goes on. So that is why counting of ribs is also important. After that, after going through the AP, this is another beautiful image taken from the Wikipedia. So in that, what happens is when you are going to have a look on the lateral view, you can notice the scapula, the hilar region, of course, thoracic vertebrae, the ribs as well, huh? Diaphragm, costophrenic angles. Of course, you can see the vertebrae, the intervertebral disc space as well. But being cardiologists or physicians, we have to focus on the other things as well. We can leave those things to the orthopedicians and the neurosurgeons, right? Okay, so we can see the ribs, in fact, also the heart as well. Okay, so one of the other things as well, which we are always concerned about, what about the airway? Is it good? Is it nice or not? Is it collapsed? So we should try to have an anatomy, anatomical picture in our brain. So this is how is the trachea going into the bronchi and the carina over here. So on the lateral view as well, this is something really important because a lot of times you're going to put up the ET tube as well, and if you're there in the cath lab, so immediately you can do a fluoroscopy and have a look as well. So now the lung anatomy. So for example, the right lung, right upper lung, right medial lobe, okay, and then comes the right lower lobe. Okay, so there seems to be slight overlap, so which you should be careful. And these are the fissures. So the minor fissure and the major fissure. So a minor fissure, as you can see, this is only in the half. However, the major fissure is the one which goes completely across. Okay, so which is the one which is dividing into the upper lobe, middle lobe, and the lower lobe. So, however, we all are aware the left lobe, left lung has only two lobes, right? So there's a major fissure. So left upper lobe, left lower lobe. So a lot of times I come across students who get confused about the right versus the left. So I try to tell them always follow that formula 3 2. So 3 means, for example, 3 is on the right side and 2 are on the left side. Similarly, 3 is also the number of valves. For example, for the tricuspid valve. Okay, tricuspid valve has 3 cusps. Tri means 3. And similarly, then when you go to the mitral valve has 2 cusps, in fact. Okay, so now coming to the zones, lung zones, which I already said it about it. Is so there are 3 zones in the right side: upper, middle, lower zone, corresponding to the second, fourth, and uh, below the middle zone, in fact. And one thing always remember that here is the one where the radiological zone doesn't correspond to the lung lobe, in fact. So whenever if you're really curious to know about it, always try to take a lateral film. So now about the cardiac anatomy. That's what we are really concerned, right? Other than, of course, the common things as well. So you should be able to see about the trachea, the clavicle, and also the different areas of the heart in this sense. So you will be able to appreciate, for example, there's a breast or mammary shadow as well, stomach bubble over here. There's apex of the heart, okay, left pulmonary artery, the knob of aortic arch. Okay, then there's a phenomenon as well, something like unfolding of aorta, the pulmonary artery branches on the right side, and several other structures as well, which I had already commented before, in fact. So let's try to have a look in some colorful pictures. Mostly X-rays are normally black and white, right? So what can we see? For example, this is the left atrium, this is the left atrial appendage, then comes the right atrium, and then comes the left ventricle, and finally the right ventricle. So one has to keep it always in mind because a lot of times, not just for the X-rays, in fact, for when someone is doing a procedure in the EP or even in the interventional cardiology, one should keep it in mind. Where are those structures? And similarly, on the now coming to our favorite lateral view. So as I was telling, trachea is the right pulmonary artery, left pulmonary artery. Okay, the aortic arch branches. So one of the common signs is called a Silhouette sign. So what is Silhouette sign? So this is the cardiac Silhouette. This it's said. So cardiac Silhouette sign is made up of. So as you can see it clearly, these are the different structures. So going along is the great vessels, pastern aortic arch, main pulmonary artery, left atrium, auricle, the left ventricle. Then over here is the IVC, RA, SVC. These are the structures, and of course the lobes as well. You can already make it out as well. The other concept which is very important is called as cardiothoracic ratio. Cardiothoracic ratio is taken mostly in PA view only. So what you try to do is you try to draw a line from a midline and you try to take measure the distance on the right side, left side, and try to divide them. And how much is it? So normal CT ratio is less than 0.5. So the other rule which I learned, especially in my medicine days, was um, I'm trying to make it easier. How shall I say? So you should try to first of all make your fist in front of the X-ray, then point out the index finger and the little finger. If the heart is going to come between that, most commonly it is normal CT ratio. Okay, the whole heart, if it comes between the index finger and the little finger, it will be normal. If it is going beyond that, chances are high that there may be cardiomegaly. But as I said it, this is a simplification. This is like a mnemonic. As I said it, I always share those shortcut tools for the students. So that's what it is. Okay. So now coming to the diaphragm. So the diaphragm, you may already notice that the right side is higher than the left side. Okay. And what happens is this is where it comes is the left costophrenic angle and the right costophrenic angle as well over here. And for example, over here comes the HeLa. So HeLa is the trachea. We'll be going into the pulmonary artery branches on the left side, on the right side, and then you will be able to notice. Then after that, one of the important things is we all have to think like, what about the dimension of the mediastinum? Is it widened or yeah? So for example, if it is this is the area of mediastinum which I was telling you. So if it is going to be more than 6 centimeter on the erect view or more than 8 on a supine, mediastinum is definitely widened. However, you may be able to notice different masses as well in the superior region, posterior region, or even the middle region. So, for example, in the superior region, you see in cases of thyroid, thymus, lymphomas, teratomas. Okay, in the middle ones, in conditions as lymphadenopathy, aortic aneurysm, pericardial cysts, dilated esophagus, or hiatus hernia as well. However, in the posterior side, you see in terms of neurogenic tumors or even the spinal masses as well. So something we call it in radiology is like the hidden areas. In hidden areas, what happens is um, it's not always so clear. So what are those hidden areas? So in terms of epics, what happens is because there are ribs which are going to obscure them. So that is why it is slightly hidden. Then comes around the cardiac shadows, because what is happening is it is hiding portions of the lung as well. And also for the lung, which is lung area, which is posterior to the diaphragm, because they are the ones which is hidden by the liver, stomach, and spleen. So these are the hidden areas you should try, especially not to miss whenever you are seeing a patient. So that's why it is becoming very, very important a lot of times. As I said it, so to summarize, so this is how is the inside out approach. As I had already said it, A B C D E F G H, A B C D H. So can one recall what did I mean by that? So airway, bones, cardiac shadow, D for diaphragm, E for effusion, F for fields of lung, G for gastric bubble, H for hyla. So you all can repeat just with me, so it will be easier for you to remember for life, in fact. Okay. So the what is the unique approach? How do you interpret the chest X-ray? A for everyone is sleeping already in the lecture, is it? A for airway, B for bone, C for cardiac shadow, D for the diaphragm, E for effusion, F for lung fields, G for the gastric, H for the HeLa and mediastinum. Okay, so now since you all have become really big experts, let's try to show you some of the pathological uh, uh, chest x-rays, especially in cardiac, okay? We all are in cardiology, right? So what tends to happen? These are some of those common chest X-rays in cardiology which we come across. So let's try to have a look. So what is happening in the RV enlargement? So already diagnosis is given. So what is happening is, if you'll be looking carefully, CT ratio, cardiothoracic ratio is definitely enlarged, okay, and the cardiac apex is rounded and also elevated, in fact. And if we look carefully at the CP angle, cardiophrenic angle also, that is also acute, in fact. So that is a indirect sign towards the right ventricular enlargement. So what is the difference for the left ventricular enlargement? Similarly, CT ratios, of course, increased. The cardiac apex is displaced downwards and to the left as well. And the cardiophrenic angle is obtuse, and in fact it tends to merge with the diaphragm itself. So did you notice the difference? Only the if the RV enlargement is there, cardiophrenic angle is acute, in fact. In LV it is obtuse, and the cardiac apex is more of rounded, in fact, and it goes above the diaphragm for the RV enlargement. However, for the LV enlargement, if it is going to be there, it is going to merge with the diaphragm. Now, a very favorite X-ray, especially in medical examinations, they try to give mitral stenosis. So, mitral stenosis, what do you see? So there is, of course, cardiomegaly, but of the RV type. And the left border, if you look carefully, it is almost the straightening of the left border, and what is called as the double right heart border. Double right heart border, why? What happens is, because mitral stenosis, if you look carefully over here, so what happens is, in the mitral stenosis, not only there is severe enlargement of the left atrium, okay, but also what happens is yeah, mostly LA is the one which is really enlarged, in fact, and that is where the problem happens. And due to the pulmonary congestion is going to be there as well, then also it may lead to the RV enlargement as well. Okay, so that is what is characteristic of the mitral stenosis. So which is uh, characterized by mitralization of the heart. So for example, so if you look carefully over here, so the aortic knuckle is very small, but the pulmonary conus is enlarged. Left atrial appendage over here, as we can see it over here, it is pretty prominent. However, if you're trying to look just at the left border of the heart, it's no change at all, because the pathology is lying in the mitral stenosis and it is stenosed. So that is why there is big amount of blood reflux happening into the proximal chambers, not into distal chambers. So that is why left atrium gets enlarged as well. Okay. So after this, if you have been able to understand what is this kind of heart, I'm such a sweet person. I have already given you all the answers as well. Okay. Um, so this is what is called as a classical congestive heart failure X-ray. Why? Because you can see the increased interstitial markings, and the upper zone vascular redistribution is overseen as well. And similarly, if you look carefully, there's bilateral pleural effusion with cardiomegaly, and the cardiomegaly is of LV type. Because there is obtuse cardiophrenic angle, and also it tends to merge almost with the diaphragm. So in the congestive heart failure, the when you will be looking, how does it's a bat wing appearance, in fact, and you can also see the curly B signs. Okay, I already said it. Pleural effusion can also be seen as well. So one of the other important things, what we are always concerned is, what about, is there any pericardial effusion? In pericardial effusion, it is called as water bottle sign. So in water bottle sign, there will be more of a globular heart shadow. So everywhere, classical water bottle sign. So water bottle is, the bottle is filled with water, right? So similarly, the heart pericardium is filled with water. That is what is pericardial effusion, water bottle sign. So one of the other important things what we always come across is the pulmonary hypertension. So what is the pulmonary hypertension? So pulmonary arteries are pretty much enlarged, okay? And so when we notice is in the PA view especially, there will be like up to 16 millimeter of the right descending pulmonary artery is prominent. And for the left side, and especially seen more in the lateral views, is 18 millimeter. Okay, the pulmonary outflow tract is going to be more prominent. The peripheral pulmonary vessels pruning is going to be there. So pruning, what is pruning actually? So for example, what happens is if we look carefully over here, these proximal vessels are very prominent, but distally they are absent. We can't even see them at all. So this is what is called as pruning. And of course, the right ventricular hypertrophy. So what is this sign? So what do you see on the X-ray? Okay, I'll give you a hint. This is congenital heart disease. Bootleg syndrome. What do you see? So you notice this. So this is more of a upturned cardiac apex, right? So you notice right ventricular hypertrophy. It's not always present, but in majority of the patients, like up to two-thirds of the patients with TOF will be having this. So the narrow upper part of the boot results from a small or absent main pulmonary artery, partly caused by a narrow infundibulum and hypoplastic main pulmonary artery. Okay, so let's try to give you refresh the whatever we all have learned. So if you all can recall, the normal pulmonary vasculature is this is how it looks like. Okay, so there's an orderly tapering and branching towards the periphery, and the vessels become invisible, and the subpleural lesions of the lungs, in fact. Okay, and then the lower lung zone vessels are greater in size and number as compared to the upper zone vessels. So what it looks like. So to be able to describe what is abnormal, we should be able to know normal first. So that is what is very, very important. As I had already said, it is yes, it can be seen normally in pulmonary stenosis, aortic stenosis, even left to right shunts as well. You will be able to see those lung vessels. So that is why to be able to identify the pulmonary lung vasculature is very important. In the sense, as I said it, you should be able to only when you know what is normal, one will be able to tell. Okay, this is good. This is not good, right? So what is happening over here? So what is happening in this field? So as you can already see, the individual vessels are dilated and also tortuous, which is extending into the periphery. So this is characteristic of increased pulmonary blood flow. Yeah. So the increased pulmonary blood flow is happening over here. If you want to see more, I'll show you more. Increased pulmonary blood flow. So what is happening is in such cases, for example, in this one, this is a special one. The diameter of the RDA means, I mean, right descending pulmonary artery is bigger than the diameter of the trachea. So always use them as references. For example, yeah, if you will be able to notice the trachea size here, and the right descending pulmonary artery. Of course, the RDPA is bigger than this. So similarly, what is happening over here? So there are some these concave main pulmonary artery. It's happening in conditions as if there is hyperplastic pulmonary artery, if the absent pulmonary artery is there, otherwise also abnormally placed pulmonary arteries. And then comes the dilated main pulmonary artery. So it is due to the post-stenotic dilatation or increased pulmonary blood flow. Also in cases of increased pressure in the pulmonary artery, of course, as well. So after you have been able to see like this, so what is the step two? What is the second step? So you should analyze the main pulmonary artery. So is it normal in size, dilated or concave? So which you already had a look as well. So after this, as I said it, pulmonary vascular pattern is very important in determining the initial treatment. Why is it? Because if uh, if it is normal, if there is a congenital associated congenital heart disease on echo, there is no immediate palliation is needed. However, if there is increased blood flow, shunt closure or of course artery banding may be needed. However, if there is decreased blood flow, then flow augmentation with shunt should be done. And if there is pulmonary venous congestion, then you should correct the left-sided obstructive lesion or heart failure, in fact. Then comes the pulmonary venous congestion. So it is a common thing, a lot of times, especially in the emergency, a patient is going to come with pulmonary venous congestion. So where do you see? We already showed you some of the examples, like the mitral valve disease, cotriatum, cotriatum. So this is more of a tongue twister word, huh? And the TAPVR with obstruction, otherwise also the hypoplastic left heart syndrome as well, you can see. So how does the X-ray look like? We are talking about radiology, right? So let's try to see some examples. So if you look carefully, so this is what is characteristic of the alveolar edema. So huge pulmonary venous congestion, bad lung. So one should be really taking immediate care of this. So when it comes to interstitial edema, especially over here, around here, you can really have a look. Yeah. Examples is something which is really, really important, as I'm telling you. And then comes the redistribution of the. So with passage of time, yes, it can be redistributing as well. So pulmonary congestion can also happen. So similarly, decreased pulmonary blood flow can also happen. But what are the conditions for that? It happens with TOF, critical pulmonary stenosis, tricuspid valve atresia, and even pulmonary valve atresia as well. So what are the what are those areas as I was telling you? So so if you look carefully, so pulmonary over here, this is the normal one. So for example, you will see whitishness which is there present everywhere over here and all. However, if you look only in this region, it is more of a whitish. Otherwise, in other areas, it is pretty dark. So this is what is meaning of decreased pulmonary blood flow. Then again in this area. So this is what is characteristically called as hyperlucent lungs, in which you see thin, stringy pulmonary vessels. And you are already smart enough, so you already know the conditions as well. So even in this as well, you see there's more of a hyperlucent lungs, thin, stringy pulmonary vessels. So now coming to the increased pulmonary blood flow, it can happen in two conditions. Either it can be cyanotic, otherwise it can be non-cyanotic. Cyanotic can be in terms of the transposition of great arteries, patent truncus arteriosus, or even TAPVC, or in conditions like single ventricle. So there can be non-cyanotic conditions as well, which is associated with um, increased pulmonary blood flow, like the VSD, ASD, PDA, or PAPVCs as well. So why I was telling you, so for example, this is how is the normal one. So there is good exposure, which we can see in this lateral film. Okay, but what happens is over here, this is more whitish, right? Hmm? There's those blood vessels, they seem to be more whitish. So this is what is more characteristic of the increased pulmonary blood flow, in fact. And the diameter of the pulmonary artery is, of course, bigger than the accompanying bronchus as well. So, being cardiologists, yes, we are concerned about the heart, but what about the lung? So, lung can also have some common problems which is associated which are seen in day-to-day life as well. So, I have tried to include them as well. So, if you will remember, I was talking about the radiopacity, the whitishness, or the radiolucency. Radiopacity, where you see the pleural effusion can be there, consolidation, collapse, fibrosis, medullary lesions, or the lymphadenopathy, or even the pulmonary edema can be seen. The radiolucency is, so for example, the lung fields will appear pretty black. So it can happen in conditions like the pneumothorax, hydropneumothorax, emphysema, or even the subcutaneous emphysema as well. So let's first of all try to have a look on the pleural effusion. I already showed you some of those examples. So what do you notice over here? Anyone would like to describe? Try.
The costophrenic angle is gone.
Gone. Gone where?
Uh, we cannot see the costophrenic
Okay,
angle.
good, good, good. So this is how will you describe the X-ray? I taught so many shortcuts as well. Okay, good. That's a good thinking, in fact. So I really appreciate it. So what happens is the other thing is how do you can you comment also about the amount of pleural effusion? Is it how much ml is it? Is it mild or minimal pleural effusion, moderate or very severe? So even with the X-ray, if if you are able to determine the pleural effusion only in chest X-ray lateral decubitus, it is going to be 10 to 50 ml. Okay. However, if in chest X-ray PA view, if you are able to determine, it is going to be almost 150 to 175 ml. Otherwise, with the ultrasound in the thorax region, even if it is as little as 3 to 5 ml, you will be able to determine it, in fact. So now coming, yeah, so that's what I was talking about. So what about the consolidation? So about the consolidation, what happens is, you can see over here, right? And then comes is the collapse. So what do you notice in collapse? Anyone would like to try?
Shifting of trachea,
Good, good, good. And
lung opacities,
so what happens is atelectasis or collapse or even incomplete expansion is one of the most common uh, finding which tends to happen. So what happens is, as you may notice, so there is opacification over here. As our friend also rightly pointed it out, in fact, over here, um, uh, there can be various etiologies for that. If there is a mucus plugging is there, or there is aspirated foreign material, in fact, as well. So, for example, a child comes who says that the mother complains that the boy sniffed in some dust or some some solid stuff as well, like this. Okay, so that is what you may be able to notice over here. And of course, it tends to correspond to the different lung fields as well. Wonderful. So you all are now the expert masters in this as well. So these are the different examples if you will see. So this is for the right upper lobe. Hmm?
Collapse.
Yes, exactly, and or atelectasis as well. So over here in this, like almost the middle and the lower right side is all gone. So you can literally pinpoint as well. So that's why it's really important to have a look. So what about fibrosis? What are the changes you notice in fibrosis of lung?
Lifting of trachea on the same side.
Okay. Interesting. And
Opposite sides lung opacities are there.
uh,
White lung will be there.
see, only it's very. I really appreciate it, but why others are not telling? We have a lot of people as well, other students, online. I can already see the list. It's pretty huge. Good number of students are there online, but no one is telling. So let's try to see, for example, what are the possible etiologies where it can happen. So the possible etiologies is if there is respiratory failure, pulmonary hypertension, or even the heart failure as well,
Yes,
right?
sir.
Right. So then what happens is, then what do you notice? So what do you notice over here is someone has already said about all these things. So what do we notice?
Uh, Cardiac shadow is also dilated, sir. Cardiac chamber,
Good, good. And
which is and there is a fusion in the left costophrenic angle. There is mild effusion is also there.
wonderful, wonderful.
The terminal bronchioles are fibrosed.
So for example, for pulmonary fibrosis, what are the other tests would you like to do?
So VQ scan,
Wonderful. HRCT.
HRCT is not.
Yes, HRCT is going to be really something. And what are the clinical things you will be able to notice? If you're there with a stet, what can you
also
notice?
will be raised JVP sign, raised JVP.
It depends upon the etiology. So what will happen is with your there with a stet, so if you'll put your stet on those regions, maybe sometimes you may be able to, yeah, hear fine inspiratory crackles at the lung bases. You may be able to hear, right? Hmm.
Yes.
So we were talking about, we all are concerned about the money, but in chest X-rays as well, we also talk about coins as well. So what is coin lesion? Coin lesions, they are, for example, up to 40% of the times they are malignant. So if you see such patients, rule out malignancy. So this is one of the important things, especially for all the doctors, I would really like to say. So what happens is the differential diagnosis for this is going to be bronchial carcinoma, adenoma, the lung abscesses, the pseudotumor, the heightened cyst, in fact, the rheumatoid nodule, or also the Wegener's nodule as well. So this is something really, really important. So we all should keep always in our mind as well whenever we are thinking about it. So now comes is one of the miliary lesions. I think everyone can already say about it. So what are miliary lesions actually? Why is it called? Why is it called as a miliary lesion?
Small multiple opacity will be seen in whole distributed irregularly in the lungs.
Wonderful, wonderful, wonderful. So this is what is happening is due to the tiny size of those lesions, which is around 1 to typically 5 millimeters. Okay, and this is one of the like up to 20% of those extrapulmonary tuberculosis cases as well. One may be able to see. So There's also differential diagnosis as well in sarcoidosis or pulmonary eosinophilia, histoplasmosis, or pneumoconiosis as well. One may be able to see. So, as I was telling you, so for example, over here the miliary nodules are less than 2 millimeters, as I was telling you. Pulmonary nodules can also be of different sizes as well, up to ranging from 7 to 30 millimeter, and sometimes pulmonary masses as well. If there is a massive pulmonary tuberculosis, you may be able to see those pulmonary masses as well. So if you look carefully over here, this is a typical X-ray of a pulmonary tuberculosis patient. You must never miss it, even in your dreams, I would say. Yeah, the masses are there, huge, mega masses. And over here, miliary small nodules, and there are also pulmonary nodules as well, in fact. So some of those, so these are the signs of pulmonary metastasis. So if you again you see something like this, miliary nodules, pulmonary nodules, or pulmonary masses, alert, a red alert, it should be there in your, uh, and you should alert not only yourself but also to the patient as well. Then comes the lung masses, which you may be able to notice it over here. Then the HeLa lymphadenopathy. So HeLa lymphadenopathy is another characteristic thing which you may be able to see either only on one side, unilateral one, or the bilateral side. So unilateral is more of in tuberculosis, lymphomas, or histoplasmosis. However, the bilateral side, of course, also in tuberculosis as well, sarcoidosis, lymphomas, or pneumoconiosis, especially like silicosis. So the silicosis is more like a occupational lung disease, so seen in the lungs of these people who are working in the silica industry, in fact, and due to inhalation of the silica dust granules in their lungs, this is going to be there, in fact. So that's why one needs to be slightly bit more careful. And pulmonary edema, you all are now the master, I would say. You all will not be able to forget, right? I've already shown you some examples now. Um, Over here, one of the important things which I really wanted to highlight was about the cardiogenic pulmonary edema or the non-cardiogenic pulmonary edema, ARDS, that is what is called as. So it is very important to diagnose that. And why am I talking about this is because a lot of times, especially if a patient is there in the ICU, so you will have to differentiate between those two, because when you want to do the prognostication of the patient, or even if you want to initiate the treatment or the therapy for the patient as well, you should be able to differentiate it. So for example, if it is a cardiogenic pulmonary edema, so of course the heart size is going to be enlarged. However, in the ARDS, acute respiratory distress syndrome, so in which the mean etiology is lying in the lungs, so here the heart size is going to be normal. Similarly, about the vascular distribution, if you are going to look, it is going to be either balanced or in fact inverted as well. In the ARDS, the vascular distribution is almost normal or balanced, in fact. Similarly, the edema, if you try to talk, in the heart, the cardiogenic cause, it is more even or central, in fact, the edema is going to be. However, in the respiratory cause, the edema is going to be much more widespread. So, for example, you are able to at least see some clear lung zones and all. Over here, not at all. You can't see anything at all, in fact. So, as I was telling you, pleural effusions, yes, quite a lot. It's pretty common in the LV failure. However, in the ARDS, mostly it is not usually present, and the septal lines or even the peribronchial cuffing is pretty much common in the cardiogenic pulmonary edema, in fact. Okay, and the ear bronchograms is most commonly seen in the ARDS. So now you are able to understand not just the to be able to differentiate the ARDS, but also from the different causes, right? So, for example, if it has been caused by the lung problem, or is it caused by something else? Hmm. So, what about hemithorax? So, what is happening over here? Can anyone recall? Okay, let's try to make it easier for you. So, what is happening over here? So, this is the condition. What is happening is hemithorax. And why is it called as hemithorax? Because,
Single slit lung is pathological.
right, right. So, what is happening is you can see only the half of the thorax. So, that is why it is called as hemithorax. So, there are three different things which you can see. So, the mediastinum can be pushed away from the opacification. So, this is the opacification, right? This is the opacification. So, the once it can be mediastinum is pushed away from the opacification. Second can be is towards the opacification. For example, in this, if you'll notice, and this as well, towards the opacification. Otherwise, the third thing is going to be is it will remain in the middle. Okay, so these are different types of opacification. So in this is remaining in the middle, and this is getting pushed towards the opacification, right? And in this, it is away, right? So these are the three types. So what are those three types? So it is going to be pushed away from the opacification. For example, this is the first type. So this could be is a pleural effusion if there is a large lung mass. Otherwise, if there is a diaphragmatic hernia as well. So that is where it is going to be pushed away. However, it is going to be pushed towards the opacify, towards the opacify sides. So, for example, if you look over here in the last X-ray, if there is a lung collapse, there is a pneumonectomy, otherwise also pulmonary hypoplasia, or there is a pulmonary agenesis as well. So then you will be able to see this towards the opacified side. And the last one, as I was telling you, so it remains in the middle in terms of consolidation. If there is a pleural chest wall mass, otherwise also there can be some combination of pathologies as well. So these were some of those beautiful examples. Oh, hmm. So what is this one? So already I have given the diagnosis. Pneumothorax.
Me,
Why?
mediastinum is
Why is it pneumothorax? Now the question comes is why is it pneumothorax?
Air in the thoracic cavity, sir.
Great, great. And what else?
And
So what happens is you should try to look for the outer
margin.
margin, exactly, the outer margin of the visceral pleura or and lung. So what is the pleural line? If you are able to see the pleural line, run, 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 emergency. You should try to immediately start arranging the things with which you are going to intervene. So a lot of times, a procedure has been done, ablation procedure is done. Otherwise, um, yeah, exactly. Yes, yes. So cath procedure has been done, and then patient complains, shortness of breath and all. Then you get this X-ray. So this is the time for action. So this is how you differentiate. As I was telling you, if you are able to demonstrate the outer margin of the visceral pleura and lung, the pleural line, from the parietal pleura. Parietal pleura and visceral pleura is different. So if you are able to see this line, Then this is what is the classical pneumothorax. Okay, now hydropneumothorax. Come on, try to understand the English. Hydropneumothorax.
Any chylous fluid or any kind of fluid in a pleural cavity.
Okay, good, good. But how do you
Fluid
see?
and air.
Exactly. So you are able to see not just air, but also fluid as well. So do you notice the straight line here and the straight line over here? And you should ideally do in a upright chest X-ray. So you are able to see it's a huge, not just air is there, but also fluid as well. So this is hydro pneumothorax. You are already the masters now. Pneumothorax, you know, hydro is also there now. Okay. Hmm. So the pulmonary cavity. What else do you see? So this is what I call it as a cavity. Cavity is standing for carcinoma, autoimmune disease like the Wegener's granulomatosis or the rheumatoid nodules, the vascular like the emboli, septic or bland, or otherwise infection or abscess. For the bacterial like Klebsiella, Staphylococcus, and Iberic infections, T for trauma, or even in some of those young patients of congenital heart disease or bronchogenic cysts as well, pulmonary cavity. So what do you see over here? Oops, okay, I already gave you the answer and then I'm showing you the x-ray. Ah, bad, 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 bad. Okay, but try to learn these things. So that's why it is important. So these are the pulmonary cavities which you notice. And the diagnosis, I already gave it to you, in fact. And pulmonary tuberculosis, we have already said about it. So what happens is there can be active tuberculosis, otherwise healed tuberculosis. Active will be shown with infiltrates, consolidation, hilar lymphadenopathy, otherwise the healed ones. You will see those nodules, scars, bronchiectasis, or otherwise pleural scarring can also be seen, in fact. And yeah, the you should whenever you're thinking for the pulmonary tuberculosis, always try to see in the apical or the posterior segment of the upper lobe, otherwise the superior segment of the lower lobe. So that is where you should try to always have a look. So this is the emphysema. So how do you diagnose emphysema?
Blackening of lung, hyperlucency,
Good, good, good. And then sub
air trap cavity.
wonderful, wonderful. Subcutaneous emphysema.
Air under the subcutaneous tissues.
Mm,
What? The, forgot the clinical
right.
sign is
So what
that
happens is, yes, exactly. So what happens? Subcutaneous, you all understand, right? So this is the tissue beneath the skin. So and the emphysema, you all are aware that it refers to the trapped air. So subcutaneous emphysema is when gas or air is there in the layer under the skin. Yeah, if you can notice it over here, both these beautiful X-rays. So yeah, so emphysema or COPD, you all are already aware. It is mostly referring to the hyperinflation, which is presently common, you know, and yes, the bullae or the avascularity is present, especially in the peripheral third of the lungs, okay, which I already explained why emphysema and the subcutaneous emphysema. So this is the picture which you see classically, especially in terms of the COPD patients, okay. So do you all have any questions so far? So see, mostly we should focus on the cardiological aspects, of course, if when we are getting trained for cardiology. However, we all are physicians first, so because you can always see those pulmonary vessels as well, those pulmonary pathologies as well. You will be able to notice. So at least you're not expected to be like a radiologist, trying to identify each and everything, but at least I try to identify the basic things on which you can modify your therapy, you can initiate your therapy, or the emergency conditions at least, if there needs to be an emergency. So, for example, there is a pneumothorax, patient is there, he's gasping in front of you, and you are not able to identify that. It's not good. So that is why I try to give you a little bit overview of everything.